my goodness, there's a lot of you. You'll have to pardon me. I'm not going to be doing, echoey. I'm not going to be doing a lot of graphs and technical things, and I probably won't be able to work my presentation, but I thought I would give you a little bit of a different perspective on cancer nursing, and in particular AML. So I work currently at Oxford at the Haematology Centre there with Professor Vyas, but I initially started nursing back in 1995. Oh, I've got my prompts the wrong way around. In a haematology ward. Now, I call it a haematology ward, but actually it was a room at the back of a very busy medical ward. And it had 5 beds, 4 beds in one room and a single bed for the patients that were really ill. It was haematology. They were all really ill. We were just running around all the time. I started out there as a student and then proceeded to go into haematology by accident because I was walking up the back corridor one day to go to another ward, which I'll talk about in a wee second, and the ward sister stopped me. You were a student in our ward. Where are you going? I'm going to ward 19. No. I've got a maternity post. You'll just stay here. What will you bring to the ward? I don't really know, sister. That's good. That's fine. That'll do me. Come on in. When can you start? Okay. Now, this sister was a little bit of a tyrant, and she liked to have the ward pristine. The patients all had to be sitting at the side of the bed, eating their breakfast, or before breakfast preferably. You had to have the turn-down bits in your bed the same length as her arm. She was like a big rugby player. So most of the time, I was quite small. I got my beds ripped back. And when the consultant arrived in the ward, because he, after all, was the centre of the universe, the patients better behave. I was the nurse that was always on when the consultant came round the ward with the haematology patients who weren't well, who couldn't get out of bed, who were attached up to everything. So let's just say I was always in trouble, but it wasn't always my fault. My family questioned why I wanted to do haematology nursing. And then my mum has a penchant for the overdramatic and kept saying, oh, but you know, remember your granny's friend such and such, she died with cancer. And do you remember auntie such and such, and it was all aunts through drink, because I don't actually have a big family. She suffered with that as well. Wasn't good. I don't know why you're doing it. So she wouldn't tell people that I was a cancer nurse. She would. My sister was an accountant. She was Kirsty's a nurse. Kirsty's a nurse. And I honestly wanted to work in A&E because I loved ER, and I thought, I wonder if A&E is really like ER. I did, however, come from Lanarkshire, and the area in particular was more known for being called Buckfast Alley, so certainly wasn't like Chicago. And I did question my choice. I wondered why I was training. I sound like Bond. I was training, but I was training to monitor and administer the side effects of chemotherapy. And the side effects of chemotherapy in those days were horrific. They were horrific back in 1995. My patients were really unwell. We weren't very good at acting at symptoms. We would wait on things happening. We'll wait until you're unwell and then we'll maybe do something about it. We didn't think about being proactive. We didn't think that maybe we could start things first of all and help people. So yeah, people would come into the ward and it was upsetting. They would come in and see relatives. You weren't allowed flowers in the haematology ward, and there was a whole host of things. And this was a common sight. People did actually sit with sick bowls. We were much slower at doing things, and I just don't think we had the supportive mechanism in place. But I loved haematology. I loved doing haematology. I can talk for Scotland once I'm not nervous. And this was an opportunity where I got to help and meet people who were common, everyday people who hadn't done anything wrong and were really going through something terrible, something traumatic, something life-changing. something that caused family stress and financial stress, and often in those days didn't have as good an outcome. And I felt really privileged to be able to support patients. And don't get me wrong, I would go home crying most nights because I got upset and I get attached, and I still do. And I remember when I first started nursing, one of the lecturers said, you don't get attached to the patients. That's just not what you do. And if you cry in front of a patient, you should be disciplined. Oh, well, I was crying all the time at times. And I thought, and sometimes it was tears of joy when people were going away because they would be in the ward for 9 months. And it was like, I've lost my friend. Where did they go? Who do I chat to? Who do I play cards with if it was night shift? And thankfully, things have changed. Unfortunately, sorry, Professor Vyas, I'm still not working with McDreamies. The nurses are gorgeous. But really, I've noticed a big change in the last 10 years, but particularly in the last 5 years. All of the improvements, lots of the stuff that we've heard today, lots of things that I sit in meetings and I have to go to a happy place in my head because I think my head will explode. So the geeky people over here, I don't know how they cope, but they talk about cytogenetics and we talk about myeloid panels. We have all of these influences today within nursing, and we know how maybe a patient will respond, but at the end of the day, when they come in to see me, they're a patient. I don't really know all of that stuff. That's for my professors and things to do. I'm just there to say to a patient, this is a crisis point. I'm here to help you through it. I'm the constant person. You might see different doctors throughout this. I'm the constant. I'm the person that you can ask questions to. You can ask silly questions to, because I am the queen of silly questions. I manage with the big things and I fail miserably with the small things. So, and it's sharing of best practice. It's doing things like this. It's sitting. I get quite excited. I think I'm a geek. I'm not an academic geek, but I get quite excited because I'm a geek about patients. I get excited at the fact that there is all of this stuff going on in the background that I don't really know about, and then all of a sudden a new drug appears and I think, oh, I've got something else. How am I going to manage this? What are the side effects with this? There's trials. We're given less chemotherapy. Again, I first started doing this and we did 6 cycles of chemotherapy plus a transplant. And then when my patients went to get told about a bone marrow transplant, no wonder they were distraught and terrified when they came back. I went one day with a patient to Glasgow to listen to the talk, and I came back and I was thinking, oh, I don't know how you're going to go through that. And I was meant to be supporting the patient. But now we're doing like the reduced intensity protocols, and what a difference they make to things. We're getting better, we're more proactive, we're offering people, nurses love talking about bowels, we're offering people things so that they don't get constipated, so that if they have diarrhoea, we can do something about it. We've got newer treatments, which you've heard all about. Treatments nearer to home. Why do you have to come into the hospital for something that you can give nearer to your home? Nurse-led clinics. Nurses, we're doing, there's lots of different people who are supporting nurses that are just there to support patients through. Ambulatory care. We've missed my 75 not out. I had the pleasure recently of working with some patients and doing a video. And I think as the consultants and as nurses get closer to certain ages, if you asked me when I was 21 what was old, 30 was old. Now that I can see 40 looming, 80 is not old. So we're looking at how do we treat patients. We are living longer, we're living better. And we do have to look at how we manage people through these times. We don't just give up. So I quite like it when Professor Vyas talks to a patient and he gives them options. Oh, that's fabulous, you get options. I know some people go, just tell me what you want me to do. But they're now getting options. We're not deciding what you should get. We're saying, here's what we have on offer. It's up to you to decide what you would like to do, and we'll help you through it. There's the better interaction with agencies, introducing palliative care. And palliative care, not because we think game's a bogey, it's more because they're really good at symptom management. And sometimes when you're on chemotherapy, you have complex symptoms that I can do lots of things, but I can't always, I've attached myself. I can't always manage everything to the best, so I have to involve other agencies. We're looking at psychological support, because it isn't just about physically treating you, it's about mentally treating you as well, and it's 50-50. You have to feel strong enough to go through this, and you have to feel that after it all, you have to reevaluate what you've been through, and that's often when people think, oh, crikey, look at what I've just come through, and that's when it hits them, so we have to be prepared for these things. There's days like this, which, oh, fantastic. Patient and carers days, because they're important as well. Carers are important because without them, a lot of our patients wouldn't get to the hospital, they wouldn't get through treatments. And I think that's my biggest thing now, is that the patient is the centre of the universe. Now, the doctors, we still need them, but, you know, they're not all the be-all and end-all anymore. They have to be there, and it's halfway. It is about saying, this is a joint, this is something that we're entering together. We're not skipping down fields and singing away to ourselves, but we're getting there with it. And patients are living with cancer longer, and they're living with haematological issues longer. It's not something now that strikes fear in people. It is something that we are going to be living with, and we have to move forward with that. And I think the biggest thing about today is the hope that we are getting closer, and about the passion that everybody's bringing to this. And I just think that's the one thing that's going to get us to actually beat cancers, and in that day I will be more than happy to be put out to pasture. Thanks very much for listening.